Hello, good morning, and welcome to this session of CMM Sites. I have the great pleasure of introducing my colleague, Dr. Chad Hales. He's an associate professor of neurology at Emory University School of Medicine. He's interested in cellular mechanisms of neurodegeneration. He serves as an investigator and sub-investigator for the Alzheimer's disease and frontotemporal dementia clinical research trials, and he's the co-lead of the Goizueta Alzheimer's disease-related dementia clinical core. As assistant director for social MemoryNet, he is the clinical director of the Emory Cognitive Neurology Program and the Goizueta Brain Health Institute clinical lead, and he's working on new models of care to improve patient access and personalized brain health. I have my pleasure to present him today on this lecture. Thank you, Dr. Hales. Thank you for joining.
Excellent. Thanks, Dr. Cohen. So let's go ahead and get started. So this is the title of my talk. We'll talk a little bit about the FDA-cleared biomarker test for Alzheimer's disease, this pTau217 Aβ42 plasma test. Here's my disclosures. I have support through Emory from several pharma companies for conducting clinical trials, and none of those will have any bearing on this discussion today. All right, so here's our learning objectives. To bring everybody up to speed, we'll first talk a little bit about the problem that occurred with the new, now year-old, FDA-cleared pTau217 Aβ42 ratio plasma test, which is a blood test for Alzheimer's disease. We'll have one slide that talks a little bit about alternative Alzheimer's disease biomarkers in the plasma or blood space. And then, and finally, I'll have a slide that goes through patients who should consider blood biomarker testing. And so this is a little bit of a smash up of a couple of different topics, but the theme, the running theme, of course, is the blood biomarkers as a diagnostic test for Alzheimer's disease. So we'll start today with our first poll, just so I have a good feel for the experience and expertise of our crowd. And that is, have you ordered or discussed plasma pTau217 test in clinical practice with your patients? So please answer that poll.
Yeah, let's wait 20 seconds. Emma, do you have the polls?
Yes, looks like we have 24 people, 24 of 34 have responded, so we can share the results, please. Kason?
Good.
All right, so we've got kind of a mixed group here. So looks like about half have used it and half haven't. So perfect. So as I mentioned, about a year ago, so you can see the date there, May of 2025, the FDA cleared a blood test for diagnosing Alzheimer's disease. Several years actually prior to that, another assay had been discussed and had arrived in the clinical space, but had not received FDA approval. And a brief comment about the laboratory tests that are out there on the market for Alzheimer's disease is that sometimes, or for any disease, is that sometimes blood tests are cleared by the FDA to be used as a detection mechanism for whatever disease or study or whatever that you're trying to do. And sometimes there are lab-developed tests which do not have FDA approval, but still may be very good, depending on how they were made, who developed them, and how they're conducted. And so for this particular discussion, we'll talk about the FDA-approved test, because that created quite a splash, right? If you've got a test that has been approved and can be used as a diagnostic biomarker for Alzheimer's disease, it certainly created a lot of excitement in the field from a standpoint of, well, can you start to begin thinking about using blood tests instead of some of the more invasive studies, such as spinal fluid testing or amyloid brain PET imaging. And so, this was approved, and this is I underlined here in this this blow up here, the Lumipulse G, this pTau. This is the official name for that particular test, and so this really just speaks to the platform, the Lumipulse platform, which is being used to do this particular assay. And you can see that it's for the early detection of amyloid plaques associated with Alzheimer's disease in adult patients age 55 and older. And the important part here is exhibiting signs and symptoms of disease. And so, the FDA actually was pretty smart when they put that particular statement in this press release. And I'll come back to that when we get down towards one of the last slides of our discussion today, that the important piece of exhibiting signs and symptoms of disease is critical, at least for now, as we think about diagnosing people and making sure that we're getting people the right information, but also making sure that there are things that we can do on the other side of that information. And basically what that means is, at least for now, we're trying to identify people that have symptoms that have Alzheimer's disease versus just doing these blood tests on people just to see if they have some of the changes in the brain and may not have symptoms yet. That's another whole discussion, but again, I'll come back to that in just a minute. So where, I think it's important to take a tiny step back and say, well, where's this pTau217 and Aβ42 coming from? And so, as we know, in Alzheimer's disease, you have atrophy and shrinkage in the brain. In this particular case, I'm showing you a little bit of hippocampal atrophy in the middle part of the brain at the tip of these white arrows. Of course, down at the microscopic level, you can see neurofibrillary tangles. So these are a couple of different neurons here that are being drawn. Some of them you see don't have a nucleus. You can see others have a nucleus. You see the kind of gray circle in here. And all this kind of fibrillar-like stuff, that's tau. And these are actually hand drawings, I believe, that were done by Alzheimer himself and looking under the microscope over 100 years ago. Of course, we know now that tau is a protein that has lots of different residues or amino acids that can be phosphorylated. And as you may remember back to your biochemistry or chemistry days, that your proteins and other molecules in the body can have a phosphate group added to it, so PO4. And in this particular case, this assay is measuring that phosphate group on the threonine 217 amino acid in tau. The other protein that's being measured here is beta amyloid 1-42. And as you may know, that's a fragment of amyloid. And here I'm showing you a graphic of a cell with the nucleus over here, the cell membrane here, and kind of attached in the middle of the membrane is a protein called amyloid precursor protein. And what happens to the amyloid precursor protein is you've got these little Pac-Man shaped things here, or secretases, that kind of cut that up, both inside the cell and outside the cell. And when it gets cut up on the outside of the cell, you get these little fragments that are formed. You don't really have to kind of pay attention to the monomers, oligomers, etc. But the point is that one of these tiny fragments that's produced is a piece of amyloid that represents amino acids 1-42. And so that's what gets you the beta amyloid 1-42 part. Now, to get this test done, you have to have a blood draw, which, as you know, is done in a lab. You have to have some special processing for the lab. So this actually has to be centrifuged. And then you're left with a sample that has blood cells down at the bottom and plasma up at the top, which contains the A-beta as well as the pTau. And it's this part of the sample that gets pulled off and frozen and sent off to the lab for testing. So what happened? I think it was sometime back in the fall, an announcement was made that the FDA approved assay was being paused in its utilization. And there was actually emails sent out to providers who had ordered this for their patients, and they retroactively identified some patients that needed to be contacted to say that the result of their test may not be valid. And so So why did that happen? I mean, there was all this excitement in May. You've got this new assay. It's being deployed. People are starting to use it. And then as we neared the fall of 2025, we start getting this notification that there is a problem with this particular assay. And initially, there was not a lot of clarity around what had actually, what happened to cause that problem, and to basically like a recall, like you might have for a vehicle or something. There's a recall on the test. And so this publication, which was just kind of hot off the press, just published last month, put out by the Mayo Group, helped to actually show what was going on. And when you read this short publication, it was actually this study that was used to alert the makers of this assay that there was a problem. And so let me walk you through this table, and I'll try to focus your attention down on these bottom panels. But first, let me show you what's in each of these columns, so we're all on the same page. So the first thing is that this is the pTau217 Aβ42 ratio. These two columns, this two columns here and the two columns here. The difference between the columns is that these first two columns are using the cutoffs for the assay that were designed by the company that made the result and that were included in the FDA-cleared assay language. These middle two columns used the same assay, but then the lab these were conducted at Mayo actually used basically generated their own cut points for what would be considered positive or intermediate or negative. So again, these are the FDA cleared cutoffs over here. This is using the same blood test, but basically generating new cutoffs based on the patient population that's being tested. These last two columns over on the right is actually a separate assay. So this is just the straight pTau217 that was a lab developed test that is still offered and used across many institutions that was developed at Mayo. And so this is just measuring the pTau217 levels and not using the Aβ42. So let's go down to the bottom of this bottom of this chart to walk through some of the numbers. So there's two cohorts, and what they've showed is that depending on the cohort, you can get some different numbers. But in this larger cohort, which had 252 people, using the FDA-cleared assay, the specificity was 23%. And of course, specificity is the ability to identify people who don't have disease, right? And the sensitivity is to identify people who have disease. And so in this first cohort, they did a great job of identifying everybody that had disease, but terrible job of ruling out people who didn't have disease, which means there was a high risk of false positives. When you move over to the Mayo Clinic established cutoffs, where they adjusted the cutoffs based on the patient population, the specificity was a bit better, going up to 79%. And then over here on the straight pTau217 assay, you can see that the numbers actually look even better, and they're not even using the Lumipulse FDA cleared assay, and this is just using the Mayo pTau217. So let's put this in graphical format so that you can really wrap your brain around this. So this is a chart over here on the left, which sort of shows the similar information I showed to you on the previous slide. Here I've got cohort 1 and 2. But here I'm also dividing the patient population between those who had a negative amyloid PET scan, which is a negative, and a positive amyloid PET scan, and the same here and here. And if you focus on this cohort over here, I'm going to put a box to show you the FDA cleared cut points. And so this is where the cut points were generated by the FDA assay that was approved. And what you can see is that, yes, the sensitivity of the assay was 100%. So everybody who had a positive amyloid PET scan is above that upper cutoff for that assay. So they identified absolutely every patient that had amyloid in their brain with that assay. The problem is that when you look over here at the negative population, there are a lot of patients above the upper cutoff who were called positive, who are actually negative and did not have and did not have amyloid in their brain. Now, when you add in the Mayo cutoff, so this is where they actually use the data from the patient population to drive what the cutoff should be for the assay, you see that these cutoffs did a much better job. And so you've got an upper bound to that, which is actually showing you the above that should be positive, whereas below that would be negative. And of course, there's this intermediate zone. But what you can see here is that, yeah, you've got some people in the positive that are actually showing up in that intermediate zone. But it's actually identifying, again, most of the people who are amyloid positive. But then over here, it's only identifying just a handful, maybe 3 or 4 or 5 people as positive when they aren't positive on the amyloid PET scan. And so this is what happened. They were getting too many positive results in people who had negative amyloid PET scans. And over here on the right is just the straight pTau217 assay using their lab developed, again, showing kind of a similar picture where most of the people who are negative are falling below the lower cutoff or just barely in the intermediate. Most of the people that are positive are up above or upper intermediate. And there's just a couple of people here, just like over here, that are showing a positive result on the test, but negative on the amyloid PET. And so why did this happen? And so this is where the conclusions from that publication were that the performance of the assay just yielded much worse specificity than the manufacturer claims. So again, their ability to rule out disease, the specificity was very low in that cohort. And the conclusion that it was likely due to a reagent performance issue. Now, there's a couple of possible interpretations of that. One is that maybe it's just there's a variation in the cut points from the baseline data set. And I think that's likely one of the interpretations here is that depending on the lab that conducts the test, there could be some minor variations in the population that's being tested that might suggest you need to make adjustments to those cut points. The other is that there might have been a problem with actually one of the reagents. And in particular, they didn't know which one based on the data that we have. But there was a comment that, at least in the Mayo hands, there was not a lot of shift in the pTau217 assay, suggesting that it might be the Aβ42, which is known to have some challenges with consistency and variability, and that may have been the cause. So the take-home point is there are two. One is that as a clinician, even when you have biomarker results that you feel are reliable or approved, especially positive ones, you still have to recognize that deviations could occur and that you have to continue to put this in the context with your clinical history and your other data for that particular patient. This first issue is a bit of a blow to using blood-based biomarkers as confirmatory for Alzheimer's disease. Because for that cohort that I just showed you, if everyone with a positive study had been put on amyloid targeting treatments, there would have been a lot of people on drug who don't have amyloid in their brain. It likely wouldn't have meant increased risk to those patients because their likelihood of developing the abnormality or side effects from those meds would be low if they didn't have amyloid in their brain. But from a quality of life perspective, it would have been a huge hit to get a therapy for 18 months and infusions and IVs and MRIs, and you actually don't have the condition that is treating. The other comment is that laboratories conducting these tests must verify the manufacturer diagnostic performance claims and cutoffs. And that's what Mayo found with this, is that there was just variation. And whether it was due to reagent or laboratory-based assay differences is not clear. But it really speaks to the importance of the quality controls and making sure that that they are robust within each of the with whoever is conducting these studies. So my second question is, so since the FDA cleared assay has been basically removed, what other assays have you been considering as an alternative in the blood?
Good question. Let's wait 10 seconds, Emma, and if you can share the results with us. Thank you so much.
Okay, people are voting. We have about 17, 18, 20.
Let's go ahead and populate it.
Okay, and then share the results now.
All right, so it looks like probably consistent with some of our initial responses, but some folks are using other pTau217s, which are available. pTau181, I didn't talk much about that yet, but as I showed you with tau, there's lots of other phosphate groups, and 181 is one that's actually been out there and has, I think, also been approved as a test with good negative predictive value. Glad to see nobody's using the beta amyloid 42/40 ratio in the blood. It just, again, has some of the concerns about variability, and I certainly wouldn't recommend using that as a study of choice. ApoE, I put that in there as a little bit of a distractor because it can tell us about Alzheimer's risk, but doesn't really tell us a whole lot about the presence or absence of amyloid or pathology changes in the brain. And so ApoE can be useful in discussing risk of side effects on some of the newer treatments, as well as risk of Alzheimer's, but should not be used as a biomarker otherwise. So where does this leave us? So which patients should have these plasma pTau217 tests? Of course, people who may be looking for diagnostic clarity, but may be too impaired or have exclusions for amyloid monoclonals, it can be helpful. Families are just trying to get clarity and to understand what's going on with my family member. An important caveat to this is that occasionally the pTau217, it may not fit your clinical suspicion. It may be indeterminate, or it may be on the lower side, but yet clinical suspicion is still pretty high. And so it's important when you do offer these tests that you recognize that you're likely not going to proceed with spinal fluid or amyloid PET or other testing after the blood test. And I go ahead and tell patients and families that up front, particularly if I don't think additional testing is going to really change management. An important group to use this in is if you have patients with cognitive symptoms and objective impairments that support MCI. And this really speaks to that comment that I mentioned earlier about the FDA-approved test, that it should only be used in patients who are exhibiting signs and symptoms of disease. The third category is a little bit less clear. And so I put this one here to generate a little bit of conversation, but patients with a brief cognitive screening test and provider concern for mild cognitive impairment. The comment here is caution, because a brief cognitive screen may not have enough information in it for you to draw conclusions as to whether the patient has enough impairments to support MCI. And we've had multiple patients where this has happened, gotten a screening test, wasn't followed up with additional testing. They get their biomarker testing, they come see us, they have a positive test, but their cognitive testing is normal. And they just have symptoms that might be consistent with normal aging, but because we know some of the biomarkers change in the brain early, maybe a decade before symptoms, may just have asymptomatic Alzheimer's changes in the brain. And so the word of caution here is, of course, you can use clinical discretion, but it's really important to make sure you have good data to back up your claim for mild cognitive impairment or mild dementia. This may be a moot point as we get into the future and prevention therapies become available, but for right now, these are the constraints we work under. The last one, of course, is you don't send it for these people, right? Patients who are worried about their chance of developing AD due to ApoE or family history or otherwise. They don't have symptoms. This is not the right use for a biomarker for Alzheimer's disease, at least at this point in time. So just to revisit, we briefly walked through the new FDA-cleared test and what went wrong. We saw that the specificity seemed to be a bit lower in a different cohort, suggesting that cutoffs might need to be adjusted based on the lab. There was also concern that there could have been a reagent issue contributing to that. So those are a couple of things that likely contributed to it and why it was removed. From an alternative standpoint, there are some other pTau217 assays, particularly the Mayo assay. There's one at LabCorp and Quest, which is a slightly different assay, and they're all reasonable. But again, you're still going to probably want to follow that up with spinal fluid or amyloid PET if you're really considering amyloid targeting treatments, just to make sure you're treating the right people. And then finally, the last comment is basically from my last slide. It's important that when you're doing these biomarker testings, it's in people that already have symptoms and that have objective findings that would support mild cognitive impairment or mild dementia for Alzheimer's disease, because that's the patient population that we can currently treat with the amyloid targeting therapies. Unfortunately, people who really have no symptoms and don't meet criteria for MCI just yet, they're still falling into that category of patients that would not be eligible for those treatments. Maybe one day, perhaps in a year, maybe 2 years, 3 years, we'll get the results from those prevention trials, and this conversation may change. But for now, as I mentioned, these are the constraints we work under, and it's important to make sure that we're upfront with our patients about this and try to make sure we're using that test as to the best of our ability to help with screening and diagnosis of Alzheimer's disease in patients who already have symptoms. So I will stop there and let you guys answer this last question, and I'll take any questions people may have.
Yes, great presentation, Dr. Hales. Thank you so much. We have a question from Dr. Mirk from the VA. She's saying that blood biomarkers are not available at this time at the VA Atlanta system. Can you comment on the availability and insurance coverage for this test?
Yeah, so some of them are being covered, and sometimes they're not. Hospital systems are treating these a little bit differently. In some cases, they're passing those costs on to the patient. In other cases, they're eating the costs. It kind of varies depending on the hospital system. Out of pocket, these typically cost with the CPT code that they use for these cost around $500. They were a little bit lower, but I think they made some adjustments to that. That was also one of the criticisms with the pTau217 Aβ42 assay, is that it was actually going to be twice as much as the regular pTau217 out of pocket, because they were charging you for both assays and within the hospital system. And so that's another reason to consider using just a single pTau217. But that part's been all over the place, and you just have to see what your hospital system is going to do, and it sort of depends on the patient's coverage.
Yeah, great question. It's interesting you mentioned the ApoE. I get so many referrals from primary care without a clinical diagnosis, but the ApoE was done even before knowing if the patients are eligible for anti-amyloid. So it's interesting for this group of primary care providers to kind of point out again that this is not a diagnostic test, it's just a risk factor at this time. And for example, at Grady, we have another pTau217, which is not the FDA-Cleared assay, it's not the Mayo, and we're just trying to learn the cutoff points and what it really means. And we really use it to rule out or rule in patients who are definitely too severe impaired to get any anti-amyloid drugs. So that's what we're doing, but it's not ideal either.
Yep.
Excellent. I don't know if we have any other questions. So I want to remind you that we have in these seminars next month, we have a great discussion from Dr. Sarah Turgot. So please join for this. And please don't forget to fill the QR code for the CME. And I don't know if we have any other questions or any comments. Thank you so much. That was really, really good. Excellent, Dr. Hales. I don't know if you want to add anything else. We're right on time.
Sounds like a plan. Everybody have a great day.
Thank you. Thank you so much for joining. Thank you.